Anaplastic Thyroid Carcinoma. One liner, it's an undifferentiated, extremely aggressive thyroid carcinoma that shows at least focal element of follicular differentiation and or previously differentiated thyroid carcinoma, for instance, papillary thyroid carcinoma. The epidemiology and etiology. It represents 1 to 4% of thyroid carcinomas globally. It's considered the end point of thyroid carcinomas. For instance, the thought is it obtains cumulative mutations until the tumor becomes anaplastic, such as BRAF and RAS initially, then accumulating TERT promoter mutations and P53. It can arise de novo as well. The median age is 68 years old, and survival is less than 6 months in most cases. Gross specimens are large, up to 15 centimeters. It can involve both lobes of thyroid. It's hemorrhagic, necrotic, and often has extrathyroidal extension. This is a case of going back to the point where you can have differentiated thyroid carcinoma elements. This is a case of metastatic papillary thyroid carcinoma to the cervical lymph node that became anaplastic, underwent anaplastic transformation. And you can see there's induration, abnormally large growth on the lateral side of the neck. And the gross specimen, you can see here, it's very large underneath the epidermis. And histology and cytology. Cytologically, you'll see background necrosis and neutrophils. Cells may be polygonal, rhabdoid, epithelioid, plasmacytoid, spindled, meaning that anaplastic can take on a lot of morphology. But regardless, all of them are pleomorphic with coarse chromatin, prominent nucleoli, pseudo-inclusions, and mitotic figures. And because it may arise from a differentiated thyroid carcinoma, it may see elements of other thyroid carcinomas like PTC. Histologically, you can have rhabdomyoblastic, osteosarcomatous, spindled, squamoid differentiation. Regardless of the differentiation, cytologically it is markedly pleomorphic with enlarged nuclear cytoplasmic ratio, prominent nucleoli with background neutrophils and necrosis, and you may see elements of other thyroid carcinomas. Here is an FNA showing cohesive groups of epithelioid, meaning it has abundant cytoplasm, and spindle-shaped cells with marked cellular pleomorphism and interspersed neutrophils. So this is the size of a neutrophil, and look how enlarged these cells are. There are prominent nucleoli. As you can see here, there's irregular chromatinic rim, there's hyperchromasia, possibly a mitotic figure there. And here you have some spindled cells here. Here's another example of an anaplastic thyroid carcinoma. This is an FNA stained with Diffquick showing epithelioid tumor cells with pleomorphic nuclei intermixed with necrotic debris containing neutrophils. So here are your neutrophils. And look how enlarged this nuclei is compared to your neutrophil. This kind of has a plasmacytoid morphology, which you can have in anaplastic, but also in your differential is medullary. However, in medullary, you would see amyloid. We don't see that. You would see salt and pepper chromatin, and we don't see that. And the pleomorphism is too bizarre and marked, more consistent with an anaplastic thyroid carcinoma. Here's an H&E with rhabdomyoblastic differentiation, as you can see here and here. It has abundant cytoplasm that looks a bit striated as well. And it was not only histologically looked like rhabdomyoblastic differentiation, it also stained like a rhabdomyoblast with desmin and myogenin. And background, you can see areas that don't have as much rhabdomyoblastic differentiation, but still have some pleomorphism with prominent nucleoli. This is these can be mitotic figures or apoptotic bodies, I'm not sure, but here's a definite mite and another mite as well, and another potential mite. Here is another anaplastic thyroid carcinoma with a spindled subtype, and as you can see, there is nuclear pleomorphism, and they're very enlarged compared to the red blood cell. Look how large this nuclei is with two prominent nucleoli and coarse chromatin. And look how they are different and check out this pleomorphism right here with this coarse nucleoli, as well as some abundant mitotic figures. Here is a very tricky subtype. There's anaplastic thyroid carcinoma that's paucicellular. The scant cells themselves, as you can see here, are anaplastic. Let's compare this to a background lymphocyte and look how large this cell is. But the anaplastic cells are kind of hidden by the extensive hyalinization that you can see. And so from low power, this could definitely be mistaken for a benign reactive process like Riedel thyroiditis, which does not have the abysmal prognosis that anaplastic thyroid carcinoma has. Again, look at this background reference lymphocyte and compare that to your anaplastic cells. Here is anaplastic thyroid carcinoma squamous subtype. And you have to differentiate this from a metastatic squamous cell carcinoma that arose from another site. One thing that can help you is seeing a component of a differentiated thyroid carcinoma, such as like a papillary thyroid carcinoma or follicular thyroid carcinoma. In this field of view, we don't appreciate any differentiated thyroid carcinoma. So it's really hard to assess whether this is just anaplastic with squamous subtype or a metastatic squame. As you can see, both have some intercellular bridges and keratin pearls and paradoxical maturation as well, against a desmoplastic background with abundant mites. As you can see, one mite here. And this is the anaplastic thyroid carcinoma with rhabdoid morphology, staining positive for BRAF PV600E, which can be used to help stratify patients for targeted therapy. So here is an instance where you can see a differentiated thyroid carcinoma component. So on your left, we see our anaplastic component. Look how enlarged this cell is compared to the neutrophil. And so you do see those background neutrophils as we saw on the cytologic correlate. And then compare these pleomorphic anaplastic cells to this, where you have conventional papillary thyroid carcinoma, where it's still kind of relatively maintain its nuclear polarity, although there is nuclear overlap and crowding. And then here is another differentiation between oncocytic cell thyroid carcinoma. As you can see on your left, you see abundant granularity and low NC ratio and the pink hue of the cytoplasm. And then on our right, we see much more enlarged nuclei. As you can compare this nuclei to this nuclei, we see mitotic figures, we see background neutrophils consistent with anaplastic thyroid carcinoma. And then lastly, here is anaplastic thyroid carcinoma with osteosarcomatous differentiation. You can see malignant osteoid with some cells interspersed. And then we see some suggestions of thyroid follicle. We can see thyroid follicles here. And you can just see these malignant appearing cells throughout the stroma. And some multinucleated cells as well, with increased NC ratio and hyperchromasia. Immunohistochemistry, cytokeratin will be positive in 75% of cases. Thyroglobulin is negative. Pax8 will be positive 50% of the times. P53 is greater than P53 staining will be aberrant in over 50% of cases, and the Ki67 is often high. Your differential diagnosis includes poorly differentiated thyroid carcinoma. You'll see smaller uniform cells with nested architecture. You should have less nuclear pleomorphism and less atypia. Rydell thyroiditis should have no atypia. Squamous cell carcinoma should not have any differentiated thyroid carcinoma component. Medullary thyroid carcinoma will have amyloid, salt and pepper chromatin, and neuroendocrine markers will be positive. Melanoma will be S100, HMB45, and melon A positive, and also will have pigment. And metastatic carcinoma, Pax8 is negative unless the metastatic tumor arises from the kidney or any other Pax8 positive site. And you should have absent differentiated thyroid carcinoma component. Prognosis, the mortality rate at 3 to 6 months is 90%. Treatment includes multimodal therapies, including resection, radiation, possible chemotherapy, but still, regardless, most live less than 2 years. And BRAF PV600E testing is mandatory, as they need to assess whether the patient can be treated with BRAF and MEK inhibitors. Here are my citations, and we'll see you on the next episode. Bye.